Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, and today we're going to be talking about something very important in the primary care setting, and that is recognizing and managing bipolar disorder, and especially how to differentiate it maybe from regular MDD or depression. And with me today is Dr. Chuck Vega, who is a family practitioner at UC Irvine. Chuck, how are you?
I'm doing fine, having a great summer. How about yourself, Andy?
Yeah, so far so good. Bit hot out there, but you know how it is.
Yeah. Certainly.
All right. Well, let's jump in. As I go around the country talking, I've had a lot of primary care practitioners come to my talks and say, you know what, I have to learn about this because it's hard to get mental health referrals, and I'm just seeing a lot of this. So is that kind of the situation you're in? You're seeing a lot of mood disorders?
Right. Absolutely. We see a lot of mood disorders. But for context, I work at the biggest safety net clinic here in Orange County. And so mental health is one of the biggest needs overall in terms of healthcare in the United States, but certainly among lower socioeconomic groups. And I happen to see that over 80% of my patients prefer to speak Spanish. So it's definitely a more Latino-based population where there's a lot of stigma around mental health disorders. So absolutely, it's important to get care for mental health overall. But bipolar disorder in particular is challenging because of the way it presents. So my patients don't necessarily always understand the symptoms of bipolar disorder. So they're not necessarily putting it together, how these feelings of increased energy followed by very low mood might fit together. It's really incumbent upon me to try to put those pieces together and then use the right tools for screening and then make the diagnosis.
Yeah, boy, you've just said a mouthful to react to, Chuck. I'll tell you, certainly we have to take into account cultural factors, and you're right that Latino community is not as forthcoming sometimes with psychological mental health issues, a lot of misunderstanding. And then you mentioned how difficult it is to diagnose. I always say you haven't practiced medicine until you've missed the diagnosis of bipolar disorder. And I sometimes call it the great masquerader. Let's start out with how common is bipolar, especially in a primary care setting?
Well, bipolar disorder affects about 2% or so of the world's population. But in the United States, that figure might be significantly higher, even double. And it affects men and women equally. And we do see it all the time. You're absolutely right that I think that, nobody should beat themselves up necessarily about missing a diagnosis. But the key is then you learn from that and then you go on to more proactively make the diagnosis. With that next patient or 3 patients from now, and you really start to make a difference in terms of getting the treatment right for these patients as well.
Well, that is certainly true. I have seen estimates that as high as a third of people sitting in a primary care waiting room who are thought to have regular depression actually have bipolar disorder. And part of the problem is, of course, they present when they're depressed. And it can be hard to differentiate MDD from bipolar.
Right. And so when I was thinking about this issue, you're absolutely right. So most folks present with depression. And so that's why it's important anytime you're making the diagnosis of depression, you really want to put patients through a screener for bipolar disorder because of those statistics you just cited. So I tend to use the mood disorder questionnaire. I find it's very effective. It's 17 questions. They're pretty easy to understand. The first 13 questions focus on symptoms of mania and hypomania. And it does have a good amount of internal consistency, good sensitivity. So it's a fairly accurate screener. It's not a diagnostic tool. So those patients who do have a positive screen should be further evaluated for bipolar disorder. But I think that if you use that screener on folks, and especially when you come back with a score of 0 or 1, you can feel very confident, okay, this is not bipolar disorder. And you can go on to treat, more proactively the patient's depression.
Yeah, and the MDQ is nice because it's self-rated. So I know time is of the essence in primary care, so this can be given to somebody ahead of time. And, a nurse or another healthcare technician can help you with that. Sometimes, though, Chuck, what I notice is sometimes people will say, no, 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 no. And then they come back a couple weeks later and say, I was thinking about those questions you asked me. Or they'll say, I talked to my spouse and they said I do have some of those things. So I don't think you're out of the woods completely if they screen negative. I think it's an ongoing process. And I really like what you said. I mean, we really must screen all depressed patients for bipolar. What are the consequences of missing the diagnosis, Chuck?
Well, then patients continue to, suffer with bipolar disorder, which is inappropriately treated, oftentimes, with, say, a serotonin reuptake inhibitor, which is not really in the treatment armamentarium, which puts them at higher risk for another episode of mania or hypomania, which could have severe consequences, including things like getting arrested or even suicide. So we want to, that's why we want to be careful. And just one thing I'll share is that what's the most common comorbid disorder with depressive disorders is anxiety. But I'm very used to seeing folks with anxiety. But if they're saying like, and I can't slow down, and I'm so nervous all the time, and I can't stop myself, and I stayed up all night one night, that's not your generalized anxiety disorder speaking. That's starting to move much more into last episode of hypomania. Most of what we're going to see in primary care is that bipolar type 2 disorder, where you get not those, severe manic episodes, which last for, 7 days, 14 days, and can really have some severe outcomes like being arrested. They're very clear and serve as landmarks that we should be making a diagnosis. So look for when patients are really talking about their stress levels and their anxiety, and especially the motor that can't stop. Those are big red flags for me that this might be bipolar disorder after all. It may, regardless, as you said, of what the MDQ says, if they're having those episodes, I'm very concerned.
Yeah, Chuck, I love that. And I've said for years that SSRI-resistant anxiety should really prompt you to be concerned. And I guess treatment-resistant depression in general, because as you said, our traditional antidepressants are really not effective for bipolar depression. And unfortunately, the DSM does us no favors because it describes a depressive episode exactly the same, whether it's unipolar MDD or bipolar. So unfortunately, there's nothing about the depressive episode, and so you really have to use these other clues, right? And I like the idea of screening tools. There's another one I'm not sure if you're familiar with called the RMS, the Rapid Mood Screener.
Yes, I have seen that one too, yes.
Yeah, and that's also self-reported. Either one, the MDQ or the RMS, I would say, are both really excellent tools to use and should be used, I would say.
One tip for our listeners that might help in the busy, because you mentioned how busy it is, and it is difficult to incorporate these things because oftentimes I've already managed 5 issues. Now I'm working on the mood disorder and I have to give them the MDQ. I'll give them the MDQ. I have it printed. 2, I'll give it to them when I go to do my orders. Say, can you work on this for a minute? And I'll go work on the other orders. So many times they need screening laboratory work. I'm going to check a thyroid level, complete blood count, oftentimes the comprehensive metabolic panel. While I'm and of course the vaccines and the physical therapy and the other things I dealt with in that visit as well. But while I'm doing that, and then I come back, take a look at their MDQ to clear them, and then say, okay, now let's talk about treatment for your depression.
Yeah. Yeah, that's really great. I'm really curious about how you introduce the treatment, but I want to get to that in a minute. And if I can, let's continue with helping folks to recognize and detect the bipolar first, because I think the key to bipolar is to recognize it, to be honest. Why is it important, especially to recognize and intervene early in the course of the illness?
Right. Well, because patients can suffer those more severe consequences. And the illness bipolar disorder tends to be easier to treat as patients are early in the course of illness. Once they've had established symptoms for 5 years, 10 years, it's even more difficult to treat, often requiring more medications. Those medications have side effects.
That's true.
You want to catch it earlier so you can have those better outcomes and just improve quality of life.
Yeah, I agree with you. I mean, there's certainly the psychosocial consequences, but we're learning more and more, Chuck. It may actually be progressive neurologically. In other words, the more mood episodes you have, it may be bad for the brain.
Right.
And so bipolar, sometimes I describe as like a rock rolling downhill. It kind of goes faster and faster over time. So yeah, I think it's really important to recognize early. You gave us such a great tip, Chuck, about the anxiety and the kind of agitation. Are there other kinds of clues that help you that you look for in when you're first seeing a depressed patient?
Well, I'll return the compliment and say that many times patients will come back. You're absolutely right and say, you know, when I talked to my significant other, or this one time in college. So, so I think the other pearl I would say is just really think back deeply and spend some time on it. So that might be a time where you just, so the way this practically plays out is sometimes I'll be reviewing something and say, just think for a minute. I'm going to take a look at this, to take a look back in your record to see if there's anything else, these other clues, the way we can manage this condition. But just think really hard. Was there a time? And I really like that when your motor didn't stop. That seems to resonate with people. If I have a single question, that's the way I put it. And most people in English and Spanish, mind you, do understand what I'm talking about. And then they'll be like, yeah, you know, when I was 18, I stayed awake for like 5 nights, and I never drink alcohol. And my friend came over and we binged on alcohol. And it's like, okay, there you go. And so, and again, is that diagnostic? No. But does it allow you to recognize that, as you said, and potentially get this patient initiated with treatment that's going to be effective much sooner in their course of illness? Yes, it could.
Yeah. You know, I love what you're saying here about the motor and the energy, because I have been saying for a while, if you want to waste a little time, go ahead and ask your patient about mood swings, because everybody has mood swings. It's,
right.
I've never had anybody say, no, it's not specific. But I'll tell you what is specific. I ask about energy swings. And that's exactly what you're doing. I'll say, was there a time in the past when you seemed to have more energy, didn't need as much sleep, had lots of thoughts or ideas, did something unusual? But then other times, like now when you're depressed, when you're slowed down and it's hard to get out of bed. And sometimes they look at you and go, wow, yeah. So I think that's exactly what you're doing. I love that. How about when you're taking a family history? What do you look for in the family history?
Unfortunately for my patients, many times there were, and I have this in my own family, that there were clearly cases of mental health disorders which were never appropriately diagnosed. And exactly what you said, they progressed to the point where the patient lost so much function that it was pretty much impossible to diagnose them years and years later. So I think that getting it as best a history as you can, I think we're doing a better job now in terms of appropriately diagnosing mental health disorders. Progress is slow, but I think there is some progress, and it does start with primary care. So, I guess think when you're diagnosing that patient with bipolar disorder, you're also doing a bit of community service in terms of showing the right epidemiology. And for that individual, establishing a family history is really important because their close relatives, particularly first-degree relatives, could be affected.
Yeah, that's so true. Bipolar is really highly genetic, to be honest, probably more genetic than unipolar MDD. So I find, the farther I go in my career, Chuck, the harder I dig for family history. And so I ask about family history of mental illness. I start general, certainly depression, substance abuse, family history of suicide, because bipolar, sadly, is associated with suicide. Institutionalization, hospitalization, and then a patient once, Chuck, you're going to love this, taught me this term, nervous breakdown. Anybody in your family have a nervous breakdown?
Yeah, right. Yeah,
right?
Yeah. That is old school, but yes, absolutely.
Yeah, old school.
It matters.
Well,
Definitely matters.
Well, like you said, sometimes they don't know the terminology.
Right.
And you can ask, has anybody in your family been treated with, you can say lithium or Depakote on that. I find those things less helpful. And here's the final one a patient taught me once. Who do they say you're like in the family? And you'll be amazed, because I had a patient one time say, they tell me I'm like my crazy Uncle Harry. Do you think that's important? And I went, oh my God, tell me about Harry. And it sounded like
that's a natural next question. That's a natural
isn't that
question.
Great? Yeah. The other thing, we alluded to this, I sort of mentioned treatment-resistant depression. One of the things, a friend of mine who was a primary care doc, Sloan Manning, he taught me to look for antidepressant misadventures. Isn't that a great term?
Yeah, that's a good term.
People who've been on many different antidepressants and they either didn't work or they made them worse. Or they got dramatically better and then it wore off really fast. Just things that really antidepressants shouldn't do, I guess. So those are some of the clues that I find really helpful.
One other one I might add that's just important overall is that I was just thinking back to when you were describing mood swings and energy swings. always try to put in the context of the patient, because those, the family forces, the social forces are so important. So if somebody's about to lose their job and lose their home, and they're experiencing, much more mood swings over the past 2 months, but then I always ask, did anything change in the last couple months? Well, and then, my kid was put in jail. I'm about to be evicted. My brother just died. All that, it doesn't, again, now maybe this is they always have some tendencies there, and this added stress, is a tipping point. But so the key is, maybe you could call it an adjustment disorder, but don't let it go. So have them back for a telehealth appointment a month later and ask them how it's going. Oh, well, my brother, is paroled, he's doing much better. He's actually got a really strong case. I feel a lot better now. Okay. Now I feel a lot better. I'm not going to go, rushing in there and, do some intensive workup for that individual. But we're primary care. We treat the whole patient. I think that's an advantage we do have. We don't see as many cases of bipolar disorder as psychiatry does, but we do know our patients, and we can see changes maybe in their personality, changes in their symptomatology. And we know their social context. Use all those clues and you'll find more cases.
Yeah, I love that too. And you said something very interesting. If somebody's maybe genetically vulnerable to a mood disorder, these situations can bring it out. I've sometimes said, Chuck, the brain's not well buffered. Bipolars. The bipolar brain's not well buffered. And so these kinds of stressors can throw them into a bad mood episode. And, speaking of that, another couple of clues are severe or psychotic postpartum depression. Is associated with bipolar. And then a woman who's had some depression throughout her life and gets a real bad one at menopause, which is another time when there's big hormonal shifts in the brain. I actually diagnosed a woman one time that way. And then another one, a friend of mine, Roger McIntyre, published this. And from a primary care clinic, he found that migraine headache with depression. So if you're depressed with migraine, you're 2.5 times more likely to be bipolar. So, not diagnostic, but these are all clues that point you to the right direction. And hopefully that's helpful. Yeah, I hope that's helpful.
Sure.
The other thing we look for is mixed features. We call it mixed depression or mixed features, which is you're depressed, but you have some symptoms of mania or hypomania sprinkled in. And we mentioned, agitation, anxiety, irritability. My friend Roger McIntyre has coined the 4 A's, which I think might be helpful to our audience, and that's anxiety, agitation, anger/irritability, and attentional problems like distractibility or trouble concentrating. So that might be helpful too, that you're dealing with mixed depression and possibly bipolar. Oh, all right. Let's now talk a little bit about management, and I'm very, very curious to hear how you introduce this discussion to your patients.
Right. Well, I think first and foremost, this is one where I really feel like I want to have a mental health care specialist on board with me. Because there are different options, and options are always good, but every option seems to have some limitations and or some potential drawbacks, as well as some significant benefits as well. I think the first thing that in primary care we need to do is, of course, consider where the patient is at right now. Are they at danger of self-harm? Do they need to be hospitalized? Some patients will present an acute mania, and those patients might best be off with inpatient admission. So there you're going to consult with mental health, or at least in the emergency department, directly to get patients taken in and receive the care that they need. But I am definitely not an expert on the management. I do think that I think that it is important to do something. Right. So in my practice, the average wait time to see a psychiatrist is going to be along the lines of 6 weeks or so at a minimum. And many times those appointments are missed for multiple reasons. So patients may go months. And that is definitely something that contributes to that delay in the formal diagnosis and treatment of depression. So I think that if you have a certain case in front of you, I think it is reasonable to begin treatment with a mood stabilizer in primary care with shared decision making and good counseling with the patient. But then I always will make the referral, even if it is that 2-month 6-month wait to see psychiatry, just so we can all be on the same page and get that appropriate treatment on board, the one that works best for the patient.
Yeah, that certainly makes sense. And I imagine that's kind of how you would handle diabetes as well. You'd want to have a specialist sort of co-managing or on board with you, or do you just manage the diabetes yourself?
Oh no, with type 2 diabetes, I say my endocrinologist can help me with hypopituitarism and Addison's disease, but I got type 2 diabetes. Yeah. Thank you very much. We try to be good stewards, right? In primary care, we only have so many endocrinologists. We only have so many mental health care specialists. Gosh knows, we know that. So therefore, I do try to be judicious. If I'm, same thing with a varied treatment, a major depressive disorder, a generalized anxiety disorder, I treat those in my practice. If they're successful, great. But for more resistant cases, that 5 to 10% of cases that really don't do better, and some of them, I start to wonder about the possibility of bipolar disorder in some of those cases. That's where you get your specialist involved. So, I'm not saying that every single patient with a mood disorder needs to be managed with a mental health care specialist, because that would be impossible. I'm very pragmatic, but for this one, when I'm suspecting bipolar disorder, absolutely. And you still have a role to play in terms of their management. I think that everybody should be familiar with the options for treatment, at least for stabilization, particularly if they're in a manic or hypomanic state.
Yeah, I think that's right. So, I guess you'd be comfortable with a mental health professional starting treatment, but you could certainly monitor it and manage it from there.
Well, it does require management. Oh, sorry. It does require management. So, and that's part of it. So we want to be careful with our... And I think that, the one, again, an advantage we have in primary care is we know the patient has obesity and type 2 diabetes. So those antipsychotic drugs might be a problem. They have a family history of hypothyroidism. So maybe lithium is going to be a problem. Yep. So it's definitely a more complicated treatment regimen pharmacologically. Although I think once you try it, the good news is you're very likely to be successful if you initiate therapy. It's certainly going to beat, let's do nothing and just wait, which could be a period of months. That's not appropriate. I would use the knowledge of your patient, again, share decision making, and you can find oftentimes the right treatment more often than not.
Yeah. So talking about, first of all, I always like to start with FDA approved treatments, if possible. That doesn't mean we always end up, sometimes we treat off label, but FDA approved treatments for mania, there's a lot of them. So mania ain't too hard. All the traditional mood stabilizers, the atypical antipsychotics all work for mania, including lithium, as you mentioned. Depression is really the harder aspect to treat. There's only 5 medicines FDA approved to treat bipolar depression, and all 5 of them are atypical antipsychotics, actually. There's no traditional antidepressants that are FDA approved. So, we do have a somewhat limited armamentarium to choose from here. Lamotrigine actually is helpful as an augmenter for bipolar depression as well. It kind of stabilizes mood from below. And you're certainly right that the atypical antipsychotics, we always worry about the weight and metabolic issues, although some of the newer ones are a little better. Lorazepam, for instance, cariprazine, and the newest one is lumateperone. Just quickly, Latuda, Vraylar, and Caplyta are the brand names, and they're all approved. Latuda,
that's certainly true. That's certainly true.
Yeah. Lorazepam has gone generic. That may be helpful. I want to just quickly mention lithium for a second. My good friend Jonathan Meyer just published the handbook on lithium, and he taught me a couple of things that might be helpful to the audience. One is you should always give lithium once a day in the evening, the whole dose in the evening. Now, that's totally counter to what I was taught, which was, divide it twice a day. Turns out if you give it once a day in the evening, it's actually less nephrotoxic, which is kind of interesting. And you're probably getting a more accurate blood level if you get the blood level the next morning. So I just found that fascinating.
Wow, that is really interesting.
Yeah. Also, the first clue that you're having a little problem with the kidneys is polyuria, and so you can intervene at that point potentially.
Yeah, I think
right.
lithium. We see so many patients with chronic kidney disease, and you can bet that if you use lithium over time, the glomerular filtration rate will decline faster than age. So it's something to be mindful of. So I think it's like everything else we do. You be patient centered.
Yeah.
You see where the potential trouble spots are for diabetes.
Yes.
The antipsychotic drugs aren't going to be as attractive. For CKD, it's not going to, or hypothyroid. Well, I guess if they're at risk of hypothyroidism, you really have to be careful with lithium. But the fact is, these agents are pretty effective. Lithium can prevent suicide over time. It definitely is. It's been associated with lower rates of dementia as well, which is so there's some things I really like about it. It's just those renal and thyroid effects that we have to monitor. Yeah. And we monitor we monitor metformin or any other drug where there's potential toxicity.
You're right. It's neuroprotective. Let me throw something at you. What Jonathan taught me was for the kidneys with lithium, amelioride. That's an oldie but a goodie, an old diuretic. I don't know if you ever use that one in your practice, but apparently that helps with lithium protecting.
Well, I think that I don't use amelioride particularly, but I do agree with monitoring. And so, and dual monitoring, with GFR, and then you could even think about, although it's less likely, you could get a urine albumin to creatinine ratio. But we have so many better treatments now than we used to. So your renin-angiotensin inhibitors, you can compare that and combine that with a sodium glucose cotransporter 2 or an SGLT2 inhibitor, and even finerenone in cases where they have diabetes. So what we can do in terms of folks with chronic kidney disease preventing progression, and actually, semaglutide was just shown to be effective too if you have type 2 diabetes for those last two, finerenone and semaglutide. So it's really a pretty exciting time in the renal space because they had nothing for many years, and now we've got more tools to prevent progression. So maybe that helps lithium kind of move a little bit more towards the front. But again, it's very patient specific, and the patient ultimately has to have some say in the choice as well.
Yeah, well, amelioride is very specific, though, at protecting exactly what lithium does to the kidneys. And I'm not sure about the others, but Jonathan pitches amelioride. You mentioned semaglutide. Just parenthetically, it seems like that drug does, the GLP-1s do everything. I mean, it's crazy what we're finding that they do. Kidney, heart, brain, it's just amazing.
Right. They have a lot of positive trials. Still not for everybody, though.
Yeah, that's certainly true. That is certainly true. And, as they're being used by more and more people, of course, some reports of some risks are coming out. And so we have to be careful. No drug's perfect.
No,
all right.
Absolutely.
I love what you're saying, though, about managing these medications. You don't want to set it and forget it. You do have to have an ongoing medical monitoring of all of these other things. Excuse me. One of the things that has been shown, too, exercise is actually very good for depression and good for the brain and everything else, of course, the heart, too. Do you ever preach exercise? And certainly as somebody's coming out of a mood episode feeling better, maybe they're able to do it. But what's your thoughts about exercise?
Right. Well, I'm pretty familiar with some of the literature on exercise for major depressive disorder, which is generally very positive. Of course, we love it in primary care because anytime, Andy, here's a pro for you. Anytime that you can recommend a treatment that can help with three things at once, primary care is all over that. We love being, that's why we love gabapentin. So it's everybody's taking it because it can take care of three symptoms all at one time. And so exercise is it's multiplied that by 10. You can take care of 40 different types of disorders at once. And certainly mood disorders are included in there. So many patients, especially with more severe bipolar disorder, in and of themselves have greater cardiovascular risk. We want to maintain their cardiovascular health with exercise as well. So a lot of especially aerobic exercise for those individuals. But heck, for my patients, whatever gets their pulse rate up and makes them sweat a little bit, that's great. If you like doing it, that's the most important exercise. The best exercise for you is the one you'll do regularly.
Yeah, I completely agree. You don't have to be Arnold Schwarzenegger pumping iron in the gym necessarily.
Right.
It can be something simple like walking your dog, for instance.
Yeah, always start slow and then move up, and it's pretty amazing what you can see, and it does really help. It helps with sleep, it helps with metabolism, and it definitely helps with mood as well.
Yeah. Now, one of the real challenges here, I'm sure we'll all agree, is adherence with bipolar. And one of the nasty things about bipolar is it affects parts of our brain that have to do with self-awareness, self-observation, insight, and judgment. So these people often don't think there's a problem. They don't think they need medicine. And nobody wants to take medicine anyway. But what kinds of strategies or tips do you have for monitoring and enhancing adherence?
Well, I think that there's still a stigma against mental health disorders in our community. And so therefore, I try to level set that this is another disorder, just like your hypothyroidism or hypertension.
Yeah.
It's and therefore, it's going to be listed on your problem list. The reason I have to do that is because to treat you and make you feel better and help you reach your potential, I need to have a diagnosis down. Otherwise, I can't get medications covered. You can't see a specialist. So it all flows, from the chart, frankly. So I make that clear to patients as well, so they're not shocked when they see it on their problem list.
That's good.
And tell folks that there's more hope, that we have newer treatments. They are effective and they are better tolerated. And that we have many different things we can do. And we're a team here to take care of you. That's the final message, is that really you're at the center here, and you have agency. We are going to listen to you and see what you want, and we'll work on it over time. But let's do it together, because it's always better that way.
Boy, I love that. The shared decision-making idea. Have the patient have an active participation, if you will, in their care. How do you handle, though, let's say you're going to start an atypical antipsychotic in a bipolar patient, or add it for even a unipolar depression. How do you handle that? What's the conversation like in primary care around that?
Well, so I think they're different conversations, but for bipolar disorder, it's going to be, the usual treatments that you might have heard about, or maybe oftentimes you took that 3 years ago and it didn't seem to work. The reason it didn't work was that you don't actually have the diagnosis of what's called unipolar depression. You have bipolar depression, which is a very common disorder and very treatable as well. So we have a better treatment for that that's more specific to that specific type of illness. And I think you're going to do better on it. Again, I would just emphasize, leave with a message of hope. Because if a lot of times patients are down and they may have tried four different healthcare providers, 6 different treatments, and they're just like, oh God, they're just throwing another pill at me. And I just try to make it clear, like, no, I think this is going to work. I make it very direct, like, this is going to work. It's just a question of how much it's going to work. And so I'm always hopeful, because I've got data to back up the fact that most patients will do better. Maybe not go into remission, but improve. Yeah.
Right.
And so that's the way I frame it. And I think that makes patients a little hopeful, especially when you have a trusting relationship with a patient, that it all starts from that. And and then when you're advocating something, they're more likely to buy into it, which doesn't mean they're going to be 100% adherent to treatment, but I think it improves that ratio a lot.
Yeah. You bring up something. You guys have an advantage in primary care, having that strong ongoing relationship. I agree with you. My concerns too sometimes, Chuck, is that they're going to go to the pharmacist or look on the internet and see that this is an antipsychotic for schizophrenia. Right. And they're going to say, why are you giving me this? I'm not crazy. So I sometimes right up front will address that too and say, well, these medicines are very effective for lots of different things, and that kind of stuff. Try to head that off.
I point out this a lot, like their gabapentin they're taking. No, I'm just kidding.
Yeah.
But Dr. Vega is going off and using it up. No, actually, and I don't even use that much gabapentin. Sorry for
gabapentin is. Gabapentin's very useful. I find
it's useful.
Sleep, anxiety, pain, and it can actually treat akathisia too, which is sometimes an issue with our drugs, believe it or not.
See, so you're primary care. You're primary care adjacent. When you get excited about treating several things at once, then we know you got some primary care in you.
I like that, primary care adjacent. Well, another one, of course, that I know is used a lot in primary care is quetiapine, our old friend Seroquel, which treats depression, anxiety, and sleep. So it can get a 3-for-1 deal there too.
Yeah, and that's one I think a lot of our listeners in primary care might be familiar with, and that tends to be one of my go-to agents as a starter if they have no experience with other drugs. Because I know it's going to be covered I know how effective it is. Tends to have a little bit less side effects. So therefore, I like etiapine as a starter for my patients, particularly when cost and insurance are major issues, which is almost everybody I know.
Yeah. And it's actually FDA approved for bipolar depression. The nice thing is you don't have to jack the doses all the way up to what was originally recommended. You can see antidepressant effects at 100, 150, 200 milligrams. You don't have to go to 300. Okay. One, interestingly, that is probably not as effective for bipolar depression is aripiprazole, our old friend Abilify, which is also generic and affordable. May be effective at lower doses, but the newer ones tend to be more effective. So, and you have to find the right one. Sometimes what I do too is I'll ask a patient, what are the side effects that bother you the most? If somebody says, whatever you do, I don't want to be nauseous, or whatever you do, don't make me sedated. I mean, that aids in your choice sometimes too.
Yeah, for sure. That's a really good point. Or if they happen to have some history of those problems in the past, or you're using other drugs, which frequently happens, which might be augmenting those same effects. Watch out for that.
Yeah. Yeah, drug-drug interactions are something else to be aware of. A number of our atypical antipsychotics are metabolized by cytochrome P450 enzymes, 3A4 or 2D6. And, what I'm not as familiar with all of the meds you guys use in primary care. I'm sure you're not as familiar with ours. And so I find it's very important to make sure you have an accurate list of everything they're taking and look up the interactions. It's very important.
I think that's very important. A lot of EHRs will help you with that. At the same time, I also look at, clinically speaking, how likely is it that the patient's going to have, some particular side effect, particularly when one drug might have increased or reduced potency, but you see them doing very well symptomatically on it. Yeah. And I think I'll just harp on the fact with low dosages, you're much less likely to see less of that additive effect. So low doses of two drugs, which might influence the same CP450 system, is a much better deal than high doses of those two drugs. There's a difference there.
Okay.
So you have to, I think I would just put it all in a little bit of context. And that's why, using very low dosages, I feel like oftentimes you're not going to run into those problems unless it's severe and there's, those double exclamation point warnings. Those you really want to pay attention to. But when there might be some slight change in metabolism and you already know you're on a low dose, I find that generally you're not going to get into trouble there.
Yeah. Yeah. That's very interesting. You mentioned too, some of the comorbidities. It is well known the association, cardiovascular disease, diabetes are much higher in patients with bipolar to the point where some people think there's even a genetic linkage. So it seems that we really have to monitor and treat those aggressively. And you mentioned that as well.
Right.
No matter what medicine I'm giving them, I'm still going to be really concerned about that.
Yeah, I would totally agree. Go for glycemic control, lipid control, and aggressive. Once they're under control, my personal approach is once they're under control and improved from their mental health, quality of life standpoint, go aggressively after smoking as well.
I was just you just took the words out of my mouth, Chuck. I was just going to say smoking. And then the other high comorbidity, of course, is substance abuse, substance use disorders. Right. How do you handle those discussions around, let's say, alcohol, marijuana, smoking? How do you do that in primary care?
Well, I really try to take the patient's perspective into account, and I think about risk mitigation in the long game here. So maybe if they're a 2-pack-a-day smoker, I'm not asking just, hey, let's get you on a drug like varenicline and let's have you quit in 3 weeks. It's not probably going to be a favorable outcome. So instead, I will. I'm going to work with the patient and take what they give me. Usually I start with the substances that are illicit and most likely to get the patient into serious trouble, either with things like overdose or things that exacerbate their bipolar disorder and, create real problems, say, like with getting arrested. So I'm going to focus on those first. I really need a specialist in either mental health or substance use or both, co-managing. Sometimes we're giving the exact same message, but it just clicks in, and maybe it's me or maybe it's my partners, because maybe a social worker, maybe another MD, whatever. It takes a team, but when the message clicks and patients are able to start de-escalating, a lot of times they start to see the power in themselves to do so, more confident and able to take the next step and to reach that next substance, which might be alcohol, maybe or nicotine, and they're able to have success there too. So I don't think it's I would say play the long game there, be their ally. Don't get too disappointed when there's relapses, and just kind of keep working at it. Don't lose sight of it, and because we know from evidence that works over time, that continuing that relationship is paramount to having a successful cessation of substances.
Yeah, I could not agree more, Chuck. I always like to say, don't feel like you have to close the deal the first time you bring something up.
Right.
It is an ongoing process, especially with substance abuse. I
also find that giving patients a little, I feel like giving patients a little bit of grace they actually really appreciate that. Like, oh man, here comes the smoking lecture. And it's like, no, we're not going to deal with that today. I would like to, if it's okay with you, I want to discuss that in the next, 2 visits. But for now, let's just work on your mood, because I think that's the most important thing for you today. Is that okay? And then when you say, is that okay? They're like, oh yeah.
Yeah.
So that's great. So, but I will,
yeah, but
next
you've
month,
planted
I will
a
bring
seed.
it up. If you're doing better, I am going to bring it up. Now you're doing better. It's time to start thinking about smoking cessation.
Yeah. Boy, I really like that. That's kind of a little sneaky that you're planting the seed there.
Oh no! But I mean, I think it's actually appropriate. It's just that the patients may remember, like, oh gosh, he did say he was coming back to this, but they're in a different different state, right? You've seen some improvement, you've seen some gains. If next month they're not better and the treatment I initiated failed, I'll say, we're gonna have to push it back again, but let's work on this again. Because when you're talking about smoking, you do have, I'd rather do it right than do it haphazard. And because I have definitely done that. My 13th, issue that I dealt with in the clinic was smoking cessation. I'm like, please try to quit, and here's the drug. That does not work very well. Nobody's really happy at the end of that.
Yeah. That's good. My bias is that when people are abusing substances, they're self-medicating something in a way, because all drugs of abuse, have a euphoric kind of effect, and they're probably all raising dopamine. So sometimes I take a very non-judgmental stance with the patient, and we'll even have that discussion that, it could be you're self-medicating, but you're doing it inefficiently, because all drugs of abuse are short-acting. So I say, I'm going to give you some medicine that might give your brain what it needs, but in a smoother way, more efficiently, and it's legal and all that. And
that's great.
That helps. Yeah, you can use that.
That's nice. That's a good way to put it. I'll steal that if you don't mind. Yeah,
please do. We learn from each other. I'm a big fan. And speaking of which, guess what our next topic is collaborating with specialists and
there we go.
with each other. Yeah. You mentioned that this is something you definitely try to do. How do you have that discussion with a patient that I want to refer you to a psychiatrist? I always joke, Chuck, nobody wakes up in the morning and says, oh, I want to see a psychiatrist today,
Right.
Yeah.
Well, I mean, in certain patients, when I'm talking about talk therapy, I will bring it up like, what's the most interesting thing in the world? You are, right? Yeah. You're every human being I think who's ever born finds them the most fascinating creature on the planet. How often do you get a chance to sit back and explore you a little bit? And it's like, when people may hear it that way, for some people that works. For most of my patients, it's more about, they're going to give you practical tools to help. In terms of talk therapy, it's going to help you solve that anxiety. In terms of psychiatry, I explained that, there are a lot of different treatments. This illness can be complicated. It is a variable course. So it tends to, while untreated, it may get worse over time. Treated, we can control it. But at the same time, there's going to be relapse. There's going to be tough moments. It's just really helpful to have a specialist who has a lot of experience with this disorder, co-managing you. But I'm not leaving you. I'm still here to help manage those medications along with, their top 3 other diagnoses that they have. And so, and we're going to share notes and make sure that we're on the same page. And overall, I think it's better care for you. Is that okay? And then, rarely do I get pushback, but certainly, unfortunately, you have to deal with that stigma. And I just say that, I will again assure the patient you are going to be in control here. You're going to, have a strong say in the decisions on treatment, regardless of who you see. But it's just giving you more options, and I think better at the end of the day, better overall care.
You know what else I always say is you're not crazy, number one. And you mentioned already this is a real medical condition. And I say it's genetic. It's not your fault. It's nobody's fault. That kind of thing. It's not weakness. But you know what else, Chuck, I'd like to suggest to our audience, there is a resource that I give to every patient and their family with bipolar. The national organization that deals with this, national advocacy organization, is called the Depression and Bipolar Support Alliance, DBSA. And I always give them the DBSA website, which is DBS and then the word alliance.org, dbsalliance.org. A lot of times I tell them, go look at this, and they come back and say, wow, you're right. That does sound like me. And for families, it can give a lot of practical tips, things to look for, things you can do to help support your loved one, what to watch out for, those kind of things. So I'm a big believer in education and, empowering.
That sounds great. No, absolutely. Those community resources can be very valuable. Support groups, if you have availability of them.
Yes.
All those things make a big difference, both for patients and oftentimes people who care about them.
Yeah. Well, listen, I can't believe it, but our time is up. And Chuck, I've really enjoyed this conversation. I've really hoped this was helpful to our audience, both primary care and mental health providers. And want to thank you for your time. Any final thoughts?
No, this is a great exchange. So again, I think that we are the sentinels out there when it comes to bipolar disorder. We in primary care can find it because we know our patients look for those changes in behavior, look for those symptoms where they can't shut off and that they feel like they have these variable energy periods. And then I would recommend initiating treatment, because especially in situations where you can't get mental health care immediately, by a specialist. And then partner with that care specialist and monitor patients over time. Don't set it and forget it. Make sure patients get the right therapies. And then listen to great podcasts like Dr. Cutler's here, so you can stay up on the latest and greatest in the management of bipolar disorder.
Great. Well, thanks very much. Really great tips and great advice. I want to thank you all for listening and wish you really good luck with your clinical work. For more information and for more educational offerings from the Neuroscience Education Institute, please go to our website, which is neiglobal.com, neiglobal.com, and you can find our podcasts on all the usual places you get podcasts. Thanks very much.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.